Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Infection Control Update 2014. Our objectives today are to know the standard disease control precautions, identify the role of the healthcare and lay communities in outbreak investigations, understand what detect, test, and report is and how it applies to clinical practitioners, discuss 2 outbreak investigations conducted by the Alabama Department of Public Health staff, ensure the most accurate diagnosis, testing, treatment, and reporting of notifiable diseases, locate basic disease information and proper test methods on the website adph.org/epi, determine what diseases need to be reported, how they can be reported, and time frame for reporting, and identify notifiable disease reporters. If you have any questions about anything being discussed today, please call or email our faculty presenters during our live broadcast. The 800 number and email addresses are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluations are all available online. You will need to register for this program in order to access those materials. Nurses, those of you watching for continuing education credit, I'm required to tell you the following. The Alabama Department of Public Health is an approved provider of continuing nursing education by the Alabama State Nurses Association. The association is an accredited provider of continuing nursing education by the American Nursing Credentialing Centers Commission on Accreditation. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. Instructions on how to do this can be found at the bottom of the sign-in sheet. While content may continue to be relevant, CE credit will only be awarded for 2 years from today's date, which is March 18th, 2014. There is no financial relationship between the planners of this program and the speakers. There is also no commercial support for this program. The Alabama Department of Public Health does not endorse any product that may be displayed in conjunction with any activity that might be demonstrated, nor will the department discuss any off-label use of products. As a reminder, the content of this program is based on the policies and procedures of the Alabama Department of Public Health, Alabama and federal statutes, rules, regulations, and guidelines. Viewers not employed by the Alabama Department of Public Health should always check to clarify whether the content is accurate according to the statutes, regulations, and policies of your respective jurisdictions or agency. So let's meet today's faculty presenters. We do have the Assistant State Health Officer, Dr. Mary McIntyre, or as you're otherwise known as, Dr. Mack, and Tina Pippin from the Division of Epidemiology here at the Alabama Department of Public Health. Welcome, and I understand we have a lot to cover over the next couple of hours, so we're going to go ahead and get started. I believe, Tina, you're on. Dr. McIntyre's on deck first. Okay. I'm sorry, Dr. McIntyre. I don't know where I am today.
We know.
I got that shocked look from Tina.
We know. Good morning. We have a lot of information to cover today, and hopefully you will have some questions that we'll entertain at the end of the first hour, right before we take the break, and then again at the end. So when we look specifically at this presentation is for infection control, and it is one of the requirements that you have that we need to address annually. So I'd like to start with addressing standard precautions, okay? We all know that it used to be called universal precautions, but it's all about those things that we should do every day to make sure that we're trying to reduce the potential of infection, not just to ourselves, but also, most importantly, to the people that we serve. So one of the things that we talk about that's most important is hand washing. When we deal with outbreaks, we always focus on any kind of information that we give to the public, whether we're talking about influenza prevention, trying to keep from getting any kind of infections as far as foodborne, about the importance of hand washing. And anytime you're going to be dealing with any kind of body fluids, or even, you know, if you're actually dealing with going from one patient to the next, or from one area on a single patient, you need to make sure that you're washing your hands. Soap and water, wonderful. The other thing is that in the event that you actually are wearing gloves, which is what you really should be doing when you're touching body fluids, is then when you remove those gloves, it is important to wash the hands. A lot of times people will assume that, okay, I had on gloves and they'll put on another pair, but in between those glove changes, there should actually be hand washing with soap and water. So when we look at some of the things when we don't have soap and water available, we know that hand sanitizers have actually popped up everywhere. You know, we carry them in our purses, on our purses. They're stationed also at a lot of places now where we actually see them in the grocery store. So one of the things you need to do is, if soap and water is not available, you need to actually use the hand sanitizers, okay? Now, certain ones of them, you need to make sure that the content is at least 60% alcohol. So you need to make sure that there's also indications that they have the bactericidal indications, and then we'll talk a little bit about those other indications that are present on those labels for those hand sanitizers. So use as directed by the product. So when we look at standard precautions, we've already talked a little bit about this, but it is important to put gloves on when you're going to be touching any kind of body fluids, blood, secretions, excretions. If you're working with contaminated items that have to be sanitized or cleaned, you need to make sure that this is done and that they are changed in between tests. And sometimes during a test, if you're actually working on, let's say that you have a patient that comes in and they've got multiple areas that are actually infected, and you're working on one specific area like the leg, you need to actually change the gloves in between those tests so that you're not moving contamination from one area to another area. And often that does not occur. A person will put on a pair of gloves and they will keep that pair of gloves on throughout what they're doing, and that's not the intent. We need to make sure we don't spread infection from one area to another area. Now, face protection is important, and specifically when we're dealing with any kind of materials that could contain potential contamination that can splatter, okay? We need to have a mask on, and we need to have on eye protection, because contamination to the mucous membranes, the eyes, the mouth, okay, can happen without a lot of forewarning. So you need to be prepared, and you need to be gloved up, masked up, and also when there's a potential of contamination of clothing, you also need to have on a gown, okay? And this is something that when we're looking specifically at with the procedures and generation, you shouldn't walk around. You know, we've seen some people, when you coming out of that, like a room, you don't need to be walking down the hall or other places with that material in that gown on, gloves on, and all of that. They should be removed immediately, washing of the hands occurring, so that you're not actually running the potential of causing problems and contamination in other areas, okay? So this is talking about promptly removing it, washing the hands, and avoiding transfer. So it's not appropriate to come out of a room still gowned up, gloved up, masked up, and not immediately get rid of it and wash up, okay? So don't roam the halls within what you had put on when you've actually performed the procedure, because you're running the risk of now contaminating other areas because you've transferred the bacteria and those microorganisms elsewhere. So let's talk about disinfection. One of the things that we've heard a lot about recently, and especially in the news, is about items that may be infected, that as healthcare people, that we may not be doing enough to disinfect them. One of the things that you see here is stethoscopes. How often do you actually clean your stethoscopes? Okay. Some people think that, you know, they wrap them around their necks. Okay. They use them, but they don't often think about the fact that I need to also clean that stethoscope. You know, it's a good thing to make sure that you're doing a daily cleaning at the end of the day. And also, if there's contact with a person's skin in between patients, you can simply use some of the alcohol wipes and other stuff on the little stethoscope itself, the little face piece, and then you can also do some cleaning using some of the disinfectant materials that you can wipe down that stethoscope. exam tables in between patients is not sufficient, especially when there's any visible soiling, to just move and change the paper. Okay, those tables should be clean, and they should also be clean on a frequency where it's not just a matter that I'm going to change or clean them in between a patient, but that I've got some kind of a cycle that's been identified with a schedule where I'm doing regular disinfection of those the tables and those surfaces within the exam rooms. Okay, we can become a source of infection. And that's when we talk about healthcare associated infections. They don't occur just in the hospital. They can also occur in our doctor's offices and from our clinics if we're not really careful about making sure that items are clean. One of the things that I hate is if I go into a doctor's office and I'm looking and I see that the exam table, you know, the legs and the bottoms appear that they haven't been washed down and cleansed. Doesn't take a lot to do that, and that should be something that is a task of the people that are actually working there. It shouldn't be left just to maintenance. One of the duties that we need to do is to make sure that things around us are also maintained and kept clean. So when we look at disinfectants, they come in a number of categories, and you need to make sure when you're looking at that and you're reading what they actually kill, not all of them kill everything, okay? They're pretty specific. Some of them will tell you that they're bactericidal, which means that they will kill bacteria. That doesn't mean that they will kill viruses, okay? Some of them will have a listing of multiple organisms that they actually will kill. So whenever you see "side" on the end, we're talking about being a disinfectant, but pay attention to the fact that you're dealing with something that will actually kill multiple organisms, okay? The links that are provided here will get you to specific information about sterilization and disinfection. So let's talk about disinfection in the ambulatory care center places. And we've talked a little bit about this already, about making sure that we provide a safe environment for our patients. You know, it's everybody's responsibility. It's not just one particular classification's responsibility. If you go into an area and you see that there's visible soiling or there's a spill on the floor, and I had this conversation recently with a physician, you know, if there's a spill in the on the floor, in the hall, wherever it is, you know, it is everybody's responsibility to make sure that that's cleaned up appropriately. You know, don't step over it and go to say, by the way, to the office manager, there's a spill in the hallway. Okay, we need to make sure that we take responsibility for making sure that we keep a safe environment for our patients. And that means that all of us have a responsibility to do that. Now, in this particular slide, we talk about the Spalding classification scheme. It specifically addresses the type of surfaces and what disinfectants we use, but it also talks about what that risk of or level is, whether you're dealing with intact skin versus whether you're dealing with skin that's broken. You know, it's one thing when we're dealing with skin that remains intact. There's another thing when you already have an open wound, okay? We look at the specific situation areas where the risk exists to determine what kind of disinfection and cleaning is required in order to make sure that we don't transmit those pathogens. That information can be found at the link that's here that actually gives you information to the cdc.gov website. We talk about the specific guidelines for disinfection in healthcare facilities. And it's not just talking about inpatient care. It talks about ambulatory services, and it identifies the specific type of surface, what that object is, and what the cleaning consists of. You know, KLMNO, specifically looking at what needs to happen as far as making sure that we have done the correct disinfection. So I'm going to move from that, which is really your dealing with the requirements when we're talking specifically about what needs to happen when we're dealing with standard precautions and appropriate cleaning of ambulatory care areas. And I'm going to move into some specific infections that you all need to be aware of. These are ones that are often or can be associated with contamination because of blood and improper disinfection, which is one of the reasons why we focus on standard precautions, okay? Because if we're all doing what we need to do to protect ourselves and patients, then we minimize and actually can reduce and almost eliminate the risk of any of these specific infections occurring. So let's focus first on human immunodeficiency virus, or HIV. Okay, we all know that it's a retrovirus that attacks the immune system, and what happens when we end up with AIDS is that we actually have the immune system that's shut down. Okay, the T cells lose that ability to fight infection, and basically our immune systems basically are vulnerable to attack by all kind of infections. We call those organisms opportunistic infections. And we all know and we remember in the 80s when we talked about HIV infection, pretty much when they developed the infection, it was pretty much they died, okay? We have come a long way since then with HIV infection, but what we have to talk about is that people still develop AIDS despite the multiple medications that are available out there. But it has become more of what people consider almost a chronic disease. And as a result of that, folks aren't as, as receptive to a lot of times what we try to talk about as far as prevention. People still die. And that's one of the messages we need to make sure folks understand. And it's also something that can be spread from improperly, we talk about with sexual intercourse and not actually making sure you're protected, but it can be picked up as a healthcare acquired infection. It happens rarely, okay, but it does happen. And it normally happens because there are improper precautions taken when it comes down to standard precautions. I can remember when I was in medical school, doing CPR and other things and working with wounds, blood everywhere. People would come in, you wouldn't necessarily have even the time or think about the need to grab gloves, okay? We did CPR and other stuff with not necessarily going through those proper standard precautions, which is why we're explaining to you all what it is you need to do. So this is extremely important. The next thing we talk about is hepatitis A. And I'm going to cover not just hepatitis A, but hepatitis B, C, and something that many of you might not have heard of, but hepatitis E. Okay, we used to call it non-A, non-B. Okay, so when we look specifically at hepatitis A, it is one of the things and one of the reasons why it's so important for you to wash your hands as caregivers, as healthcare professionals. Diaper changes, okay, it can be spread because the result of changing a diaper and not washing the hands. We don't think about, often we tell people be careful about it, especially focusing on putting your hands up into your face. We can rub our mouths without even thinking about it. So that's why frequent hand washing is important. Traveling to or living in countries where hepatitis A is common, that's endemic. People have to make sure that they identify in their course of travel whether or not there is a risk from the water itself or from contamination with those products, from actually knowing that I'm going to an area where this infection is endemic. I don't need to drink water, out of the faucet or, stuff. I need to make sure that I'm doing bottled water. We talk about that to people and explain and being cognizant about where the travel environment is. But household members, caregivers of anyone that's infected with hepatitis A needs to take precautions. And that includes the gloving and the frequent hand washing. When we look at hepatitis A, there is a vaccine that will prevent it. And we know that there have been some changes when it comes down to with our pediatric immunization schedule about some requirements that when we grew up, or when I came along, a lot of these vaccinations were not available. They are now, and they're given to our children when they're born. And then right after, you know, in that first couple of years, they receive vaccines for hepatitis A and B. That means that we actually, for this generation, they're at a whole lot lower risk of actually ending up with the infection than we are. But we also use what we call post-exposure immunoprophylaxis for certain populations that have been exposed. You know, when we have an outbreak situation, or we have a specific identification of a Hep A exposure potentially for, let's say, a food handler, where there may have been contamination or contact or exposure with foods that were not cooked, okay? We then identify and look to try to see if there are people that need post-exposure vaccination, okay? Now, hepatitis B and C are also, we look at blood and body fluids transmission. We talk about sharing needles and sex with infected people, occupational needle sticks, and we're going to give you some information later on, specifically where to find information when there's a needle stick and what you need to do. It can also be transferred from an infected mother to a baby during birth, but there are some things that can be done even in that situation to reduce the actual development of infection in the baby. We talked specifically about the need for immunoprophylaxis for infants that are born to hepatitis B antigen positive women, that we can actually go ahead and immunize those babies to reduce their risk of actually becoming positive. So let's talk about the resources for bloodborne pathogen exposure, and specifically for hepatitis B. There is a bloodborne pathogen exposure plan that is available. There is a form that is available for those people who decline hepatitis B. But there is no reason to decline hepatitis B vaccination, okay? There are some people, for whatever reasons, that have determined that they don't want to take the vaccine, and they have the ability to do that. There is a form that allows you to decline it. But you have to recognize then that you put yourself at risk for the development of hepatitis B if you actually end up being exposed through a needle stick, or whether it's through exposures to blood splatter, whatever, that you put yourself at risk for actually developing hepatitis B when there's really no need of this. This is available at adph.org, section B, and I'm going to actually show you a screenshot in just a minute, that a few seconds, that show you that. But review the bloodborne pathogens exposure plan if you haven't done that. And we talk about hepatitis B vaccine declination form is located on page 26 of the document, and that's Appendix B. So this is actually where you can find the information, and it's at the adph.org at the Bureau of Clinical Communicable Diseases website. And where you see the circle is actually what you click on, and it'll take you right there. Now you can also get the information for that form, which is the Appendix B, to decline the hepatitis B vaccine. Okay? We have additional resources available in the document library. We specifically have information related to employee health, isolation, and precautions that you can actually get by going to the document library and then clicking on the employee health tab. Okay. We have also loaded the Association of Professionals in Infection Control and Prevention, several different resources that are available there for infection control, isolation, precautions, and employee health section. So there are a lot of resources available to you. You just need to actually, click review them. And I would do it before there's actually an event that you need to know where to find this info. You know, maybe put you a favorite on, and so that you can actually get to the information when you need it. And this shows you where it's located in the document library. And there's an employee health tab, and you identify those various resources there. So now this is hepatitis E. This is actually one that a lot of you may not have even thought about or heard of. And it's not usually associated, or most people don't think of it as being present in the United States. We think of it as being present in developed countries, where it's usually, we normally would see it as a result of somebody having traveled outside of the United States and returning from an endemic country and then having this infection and development. But there is evidence that there are sporadic cases that have occurred in the United States with no history of travel and no clear exposure identified. We did identify that there is some evidence of potential contamination that has occurred from swine, and potentially even with some specific wildlife exposures. So we do have information related to hepatitis E so that you can actually find that documentation. The thing about it that's a little bit different from the other hepatitis that we talked about was that you don't develop a chronic condition like you can with hepatitis C, okay, or with even the B forms, but it can be severe. Usually it's self-limited, it's acute illness, and my but is, it can put people in the ICU, it can put people on ventilators, okay? Folks have required or developed renal failure because of it. So it's not something that you have to say, oh, I got hepatitis E and there's no problem. Sometimes they can be very, very, very sick, okay? There is no vaccine for hepatitis E. No vaccine. So let me introduce you to the Bureau of Communicable Diseases. We call it BCD, and it is under disease control, as the state lab also resides under disease control. But the Bureau itself is made up of 5 specific divisions. Most people think about epidemiology is where we deal with a lot of the outbreaks, where we look at and we talk about the data and the information, and we usually have a lot of info on the news, but we also have the other divisions that deal with outbreaks per se, or situations that require investigation, mitigation, okay, including the ones that you see here. Immunization, and the reason it's here is that just as we talked about hepatitis and those specific ones that could be prevented by immunization, there are vaccine preventable diseases that can occur and that we have to actually go out, deal with, investigate, and in some cases offer post-exposure prophylaxis because of them. So it does occur, and it requires the investigation and surveillance in dealing with those. So when we look up at the Bureau of Clinical Laboratories, we actually have the Montgomery lab and the Mobile lab. Those are the only 2 labs that we have that are the state laboratories. We deal with clinical chemistry, we deal with micro, and as you see here, I'm not going to read everything there, but this is where a lot and pretty much the majority of our specimens go for testing when we have outbreaks. Now, there are some things that we cannot do. There are some tests not available and that we have to work with the CDC, or we work with other state labs because we have agreements because of the, let's say, the limited volume that we actually have to actually maintain separate testing ability here would not make sense. So as a nation and really with state labs, we work together to make sure that we provide the testing needed and that we maintain the capacity to be able to do that, okay? So the Bureau of Environmental Services, or BES, is often involved in the investigations that we do. And they're included because we have to call them when we need to have any kind of environmental sampling done so that we can actually submit for testing there, try to see if we can identify what the potential sources are. You know, they have gone in with some of our dialysis. We've had some things happening at a dialysis facility. They've gone in to make sure that with the machines and those specific surfaces, you know, whether we're dealing with sinks, faucets, you know, a pool, that there may have been an outbreak occurring in a swimming pool, they assist us in doing that. But this is what they do on a day-to-day basis when it comes down to food, milk, and lodging, and actually looking at indoor air quality and solid waste. Seafood, shellfish, milk, and quality assurance. The epidemiology division in itself has 5 different branches. And when we talk about, when you see our reports that come out where we actually do the results of what we call the outbreak investigations, and we have little charts, and we have bar graphs, and we have pie charts, that's the result of actually the analysis of that data, and that includes, and it's done by the analysis and reporting branch. When we look at infection control, we actually have deal with the healthcare associated infections, and we do have the Infected Healthcare Workers Program that we recently had some revisions to include hepatitis C to that, as far as getting changes made to legislation that was introduced this session, because it did not include the hepatitis C in the current regs. The surveillance activities, and we think of those people that we have not just here at the central office but out in the field that actually help work those investigations. They go in, they complete the actual forms, they talk to the people who have been either infected or the ones, we try to get some people that are also well that it may have been at the same place to try to see if we can identify the source. Toxicology, think of Dr. John Garisco, but also those things whenever there's anything like that, mercury spills, any kind of episodes when we've got, as far as we had a mercaptan situation in Mobile, and that included and involved not just the outreach people in surveillance, but also toxicology. Zoonotic infections, Dr. D. Jones, and when we look at specifically there, we think of probably the one that we most frequently deal with, a cause related to rabies. Whether there's been a bite, from a cat, or people have noticed that there was a bat in the room, in the bedroom, or there's been a dog bite, any kind of situations. And we also look specifically at with, we had an episode with raccoons, baby raccoons, not that long ago, where somebody decided it was a bright idea to take them home, okay? So, not something that you need to do, please, okay? So let's look specifically at what our mission is: to protect the residents of Alabama through constant monitoring of the incidence and the prevalence of communicable, zoonotic, and environmentally related human diseases. So who must report? And you're going to see this again. You will see this again. Okay? That's correct. So I'm going to say, if you know about it, report it. Okay? Really, it is all of our responsibilities to do that. Okay? And don't assume that someone else has done it. We would rather get it 2 times, 3 times, 4 times than not at all. Okay? We don't have a problem with it being repeated, but we do have a problem if we're never notified. So that's why this is extremely important. Minimum data, what we need in order to do the investigation to get started. We have to have a way to contact the person, the patient. And we also need to know what it is potentially that we're trying to deal with. Sometimes the person may not know. All they know is that it's some kind of a diarrheal disease, or but this is the information which talks about the health condition. So if the disease is not known, if it's an outbreak of diarrhea, that's what we need to know, okay? And specifically who's sick, okay? The date of onset, the date of lab results, and or the date of diagnosis, and the reporter's name, reporter's phone number, in case we need to call because we get a wrong number or something in trying to contact the patient. So this is something I want all of you to pay attention to. We make calls and try to get information often, and one of the problems that we run into is, I've got to get a HIPAA release form signed by the patient. We have under HIPAA basically what is public health authority that allows us not to have an individual sign authorization from a patient when we're dealing with surveillance, investigations, and interventions for notifiable diseases. So often I'll get a call, one of the nurses will say, well, I can't get the name of the patient or the information needed from the provider or from the hospital, and I'll have to get on the phone and call. Usually that's all it takes. Sometimes we have to get legal involved and we have to fax a little letter that says we don't need authorization from the patient in order to get this information, because what we're doing is we are racing against the clock. And what we're trying to do is get the information quickly so we can try to stop things and identify what we're dealing with. Okay? So if you ever have that situation occur and someone calls and says, you know, we're calling from Alabama Department of Public Health, or you're with Alabama Department of Public Health, and we need this information specifically because we've got a situation going on that involves this investigation. You don't have to have that, and this will take you specifically to the information link here that shows that we do have, and I used to call it an exemption. It's not so much an exemption. It is part of the regulation that allows us access to that data. Now, this is our surveillance pyramid, and what I show this for is that it ranges, when we look specifically at what happens, to at the very bottom of that pyramid, the initial exposure to the general population, all the way up to the identification of the organism and the confirmation and the reporting of cases. Okay, and so I'm getting ready to turn this over to Tina, and we're right on time. I'm about 5 minutes behind, but this is to allow you now to learn a little bit about how we go about doing what we do.
And I'm going to go back to talk about this because I think this, I'm a visual person. You know, when I see it, it can relate to it. And when we do any of our training on communicable disease or outbreaks or reporting and how we need to work with the community, we ask the participants, okay, all of us in this room at some time have been exposed to an organism that could cause disease, whether it be flu, some type of gastrointestinal disease, or something else. So whether or not we become ill depends on how our immune system is, how well we're sleeping, how well we're eating, how well we're taking care of ourselves. So whether or not we become ill, a lot of factors play into that. Are we immunocompromised? So then, let's say you do become ill. Well, if I have a gastrointestinal disease, I have vomiting and diarrhea, most of the time people stay at home. They recover, they don't seek care. But then there may be those that actually go seek care. So when they go to seek care, do they get a specimen? And I think in every training I've ever done and talking with participants, if I ask people in the room how many times a physician collected a stool specimen or did anything other than a rapid test, it is few and far between. So taking that step to get a specimen obtained, and then whether or not we isolate an organism and it's a confirmed case. So this shows that the type of investigations and the type of response that we do and the way we're able to confirm cases, we're only getting just a small part of the big picture. So I just think this always speaks volumes of how much disease is out there. So today I'm going to talk about detect, test, and report, and I know that some of you have been through detect, test, and report because the surveillance nurses have really been out there trying to discuss about what it is and what we need to do. And also we've done a lot of training across the state. So today we're going to try to talk about the most accurate diagnosis, testing, and treatment for notifiable diseases, how we locate that information, the proper test, looking at what diseases need to be reported and how they can be reported, and then time frame, and then who, again, is the people that we need to report. So looking at notifiable disease condition, we had the campaign where we wrote grants to try with our ELC monies, like our epidemiology laboratory capacity grants. And I've gotten so used to saying detect, test, and report that a lot of times I can't remember what it means. So that's why we have this slide, because I've always just called it detect, test, and report. So detect, decrease epidemiologic threats with environmental controls and testing. What does that mean? That means that we are out there trying to stop the threat of disease timely by collecting specimens, doing mitigation. Do we need to stop serving meals at a daycare? Do we need to, and what do we need to test for? So that's what detect is all about, is looking at what's out there and what we need to do. Test, trying to increase our testing by the physicians and other medical providers to look at confirming disease, because so many times they make a diagnosis but we don't get the test that we need. And then reporting. Rules for every provider and organization to report on time. I know that when I was in nursing school, I studied a lot about disease. I knew about every type of system there was, respiratory, gastrointestinal, but if you asked me, I may know about salmonella. Did I know it was reportable? No. Worked in the ER for many years. If somebody came in with vomiting and diarrhea, we diagnosed it as gastrointestinal disease. We never even thought about the public health aspect. So I think that, you know, it's really important for us to get out there and explain the campaign and what needs to be reported. So the purpose of reporting notifiable disease is try to prevent disease. You know, if we can identify that salmonella case, well, are there other cases? Are there other things that we need to be looking at as far as food, or is there a contaminated product? Well, also looking at assisting with medical decisions. You know, helping that provider to look at what they have and how we can help them to identify other cases as well as maintain their patient care. Doing provider and patient education. Many times we find that some providers are not aware of the type of testing that needs to be done or the type of education and prevention. And I know that we have so many, you know, you have such a high patient load. There's so many things that are required. That kind of gets pushed to the back sometimes. But looking at notifiable disease condition, it is required by law to report. So that's what we're trying to encourage. It's in the administrative code and authorized and requires reporting, as Dr. McIntyre has already discussed, the HIPAA privacy rules. We get the HIPAA, we try to do an investigation. They say, well, we can't share this. It's a HIPAA violation. We have letters that we've already drafted to send to them, as well as rules, so that we can explain that you are not in any way sharing information that the patient is losing their confidentiality. You're required by law to provide this information for investigative purposes. So looking at within 4 hours of diagnosis, this is called an immediate, extremely urgent. And I put some demographics here to kind of look at what is, you know, things that we can look at, whether it be anthrax, botulism, tularemia, cases of nuclear, biological, or chemical terrorist agents. Now, this is not something I would think a doctor would see necessarily in his office. What we see is we get these calls and somebody we think there's been a white powder event, or we have a baby that's shown failure to thrive, head lag, constipated, poor sucking reflex, so we think it's botulism. So really for them to understand what organisms and what diseases or conditions need to be reported immediately. And when we look at cases of nuclear, biological, and chemical agents, well, we have chemical releases. We respond to those immediately. We don't know that necessarily was it just an accident at the facility or is it something else. So those are the type of events where we immediately respond and investigate. And for botulism, when we do get calls, this must go through Dr. McIntyre. We have an in-depth form to collect to look at differential diagnosis. Have they ruled out myasthenia gravis, Guillain-Barré, other types of diseases that could be the cause and not necessarily botulism? There is a shortage of antitoxin for botulism. The testing for botulism is not like you draw blood and you test. We have to actually inject mice, and the poor little mice, to see if they live or die. So this takes some, in-depth investigation. And so we're not looking at just a differential. There needs to be other information, and we have to communicate with CDC to make sure the physician understands that. So it's a lot of communication in collaboration with Dr. McIntyre and the CDC. So again, just reinforcing things that I've already talked about. Arrange for the lab testing of specimens. So we're working with the laboratory at the facility, the hospital, to determine how to get the specimen to the BCL, making sure that it's approved by the state epidemiologist, Dr. McIntyre, and looking at epi and environmental investigation. So let's think that there could be a possible botulism case, and we've had a lot of suspect infant botulism, where we've actually gone to the home. The environmentalists have helped us to go to the home where maybe the baby was given, an example was the mother had put together a certain spice formula that she thought would help the baby with colic. Well, of course, you're looking at a 4-month-old child that should be just on formula or breast milk. Giving and introducing something like spices and other things that have been bought from an herbal store, could that be a possible agent for the botulism? So they actually go into the home, they collect the suspect products, they look in the refrigerator to see if there's anything of concern. So this is when we really think there is a possible botulism. It's a very thorough and in-depth investigation, and we have to work together with the BCL for testing, with BES, environmental, for doing the site visits and collecting specimens. So it shows the collaboration with all of the different bureaus and how we have to communicate and really work together. So if it's warranted, we obtain the botulism, the antitoxin, and we try to get it as soon as possible. We work with the National Botulism Surveillance Program, which is from California. So there's only one division. It's in California. They help triage all the situations to determine if the antitoxin is needed, and the resources are provided here. So looking at reporting within 24 hours of diagnosis, extremely urgent. What we really see with this the most is hepatitis A, Haemophilus influenza invasive disease, Neisseria meningitis, or this is bacterial meningitis, not viral meningitis. We have novel influenza A viruses, and providers get this confused with seasonal flu, which is not the case. This is a virus that if we're testing for flu and we go through our usual means of PCR testing or other specific testing, not just the rapid test where they swab the throat and then swipe it, we're looking at doing in-depth testing, and we're not able to isolate what type of strain or virus it is for the influenza. That is a novel influenza A. When we're doing we're looking at updating our rules, and we look at how we will modify this so that people are not confused about the types of flu that needs to be reported. Pertussis, polio, tuberculosis, and you know that we have really seen an increase in tuberculosis cases. It has become a lot of work and mitigation and treatment. So tuberculosis is by no means gone. I've never seen it as bad as we've seen it. Typhoid fever and outbreaks of any kind. So these are the type of, we need to know about this as soon as possible, within 24 hours. And again, it has cases of potential public health importance. So what is that? So that's when a physician, looking at their patients, they see something that's just not right. And we had a good example of this is we had a pediatrician, a very astute pediatrician up in northern Alabama, who was seeing cases of hand, foot, and mouth disease. Well, it really wasn't the season for it. And not only that, we were seeing it in patients we really don't see it. We were seeing it in adults where the cases were so severe, there was sloughing of the skin of the hands and the feet, so much on one individual, he was hospitalized, he was unable to work for 2 weeks. So that pediatrician, and the pediatrician also treated the child. So they made the call to epidemiology and talked with me and pulled in Dr. McIntyre, and we said, we've got something going on. Well, of course, the first thing we were really concerned to make sure that it wasn't smallpox or something. When you have a rash that's undetermined, you have to, we always think worst case scenario, but we're looking at what needs to be done and get on this as soon as possible. And that's just great when a healthcare provider is communicating with public health, whether it's in the nurses, you in the field. Just it's so important, the relationships that y'all have with your healthcare providers, as well as working with them in the central office. So in looking at that case of potential public health importance, we were able to identify a Coxsackie A6 virus that had never been diagnosed as an outbreak in the United States. So Alabama was the first state to ever identify this as an outbreak and identify this organism. So it shows how, you know, that is looking at epidemiology, emerging infectious diseases, and that's where we're really trying to stay ahead and make sure that we report and we respond timely. So 7 days of diagnosis. There's a lot of diseases here that I don't know if you're able to read it very well, but you know, these are our enterics, our salmonellas, the campes, the listeriosis, Lyme disease, a lot of our tick-borne diseases, our arboviral diseases. And arboviral diseases, we're looking at West Nile fever, West Nile encephalitis, hepatitis B and C. So these are the ones that we generally investigate the most. So how to report. So there's many ways that you can report. Contact EPI for immediate, extremely urgent, within 4 hours of diagnosis. So that's looking at our botulism, our white powders, any of those immediately, extremely urgent. It must be a phone call. We have to be. It's not sending an email, doing a fax. I mean, we need to be called. Immediate, urgent, within 24 hours of diagnosis, so outbreaks, those other types of diseases that we discussed, they can report online. We have a report card, and we're going to talk about that in a few minutes. They can email through our report at adph.state.al.us or can send in the lab report through our secure fax. So these are ways that you can do for immediate urgent. You can also call, which we have a 1-800 number. So our 7-day diseases, our standard diseases, also again online reporting, email, fax, or some do mail in the green cards. And we're really, this is great for looking at what diseases are reportable and as well as the time frame. And I know Teresa and Marilyn do a great job when they're doing orientations that they provide these to all the new nurses so that they can understand what's reportable. And that's just key. Whether you work EPI or not, you may be the one that gets the phone call. So these are good to have around. I have them like everywhere. And I work it every day. So it's just always to have as a reference, no matter how many times you look at it. Keep it with you. So it has the 4 hours, the 24 hours, and then the 7-day. And then at the bottom, it has all the contact information for all the Bureau of Communicable Disease, the 800 numbers to call, as well as the fax numbers. So we don't get these very often, but we are really trying to push for online reporting or phone calls, really online reporting, because the electronic is the fastest way to get information and to get detailed information. But keep these. If for some reason you don't have a green card and you want some, just email. We'll provide some contact information later. This is a screenshot of the online reporting. This captures all those minimum data elements. So this is very useful. We get a lot of these every day. We get it for STDs. We get it for all types of reportable conditions. We don't get it for, of course, tuberculosis. There's others that we expect a phone call. But this is for maybe the hepatitis B, the hepatitis C, and others. And it collects that information that we need. And we send this out to our staff so they can rapidly start doing an investigation. And I apologize that this is so small. In fact, I can't read it myself. But what this shows is over the previous 12 months, how many types of investigations as well as cases we've done. So what's the difference? We investigate a lot of different lab reports for communicable diseases, general communicable diseases. Let's say Salmonella, West Nile fever. Maybe we don't have the lab report to support that, but we get a call from a physician, or we get maybe a lab report that's a suspect or possible case. We're going to investigate it. We're not going to take a chance that somebody does have a disease that needs to be investigated and there needs to be mitigation or control measures. So that's why you always see more investigation than you do cases. And cases are what meet CDC case definition to be considered either confirmed, probable, suspect, whatever is appropriate for that disease. And so we do a lot of investigations. This shows how much work the epi nurses, how much work they do in trying to identify disease and rapidly respond. Outbreaks. This has the list of outbreaks for the previous years. And I can't see my numbers. But I know that we have done a lot of norovirus outbreaks this year. This is usually starting late December, January, February, into March. We see a lot of norovirus, especially in the institutional settings. So we're talking about nursing homes, the assisted living facilities. And if you have it in the nursing homes where people are living there, they're not out in the public, think about how much norovirus is out in the community. We see more norovirus than we see anything. And when you think about norovirus, you're thinking about the cruise ship virus. And it only takes a little bit of the organism to make a lot of people sick. And for 24 hours, you're really sick. So we do a lot of investigations and a lot of outbreak investigations. And generally, we do see the most are institutional settings, and we do flu outbreaks, and we see a lot of that in the institutional as well. So again, looking at who must report. Physicians, dentists, nurses, all of you, medical examiners, hospital administrators, nursing home administrators, laboratory directors. And I want to talk a little bit about this before I go to the next slide. And just to reemphasize that a lot of times people don't know they need to report. They don't know what to report or how to report. So that's why education, the epi nurses that are getting out to do this, and we're meeting anybody that will listen to us, whether it be Board of Education. We're looking at nursing home associations. We go to foster care to try to look at who we can meet and how we can educate so that everybody knows. So, because physicians a lot of times may not know that it needs to be reported. Dentist, and sometimes it may not be the dentist is testing. They may just, in talking with the patient tells them that they have a disease, salmonella, or I was recently diagnosed, and they should call us. Medical examiners, hospital administrators, nursing home administrators. And we probably get more from the nursing home administrators than the hospital administrators, because generally the hospital administrators, unless it's an outbreak, are really not going to be aware of the clinical diagnosis. Laboratory directors. This is critical. We are seeing that the laboratory directors a lot of times will call the infection preventionists, the hospital staff, and let them know, okay, I have a positive reportable condition. Well, they think, okay, that's the end of it. I've reported it. Well, no, because the laboratory directors or any laboratorian that has resulted a test of a reportable condition should be calling public health. So we are looking and getting out our nurses. We have a weekly conference call so we can talk about anything going on. And this is the area that we've really identified as a need for the laboratory directors to have that relationship with epidemiology and with reporting to us so that we can timely investigate. Because the closer we can get to that collection date of that specimen and that illness onset, the more we can get information that is key to preventing disease. That's just critical. So, the faster and closer we can get to that illness date, the more we can know. School principals. daycare center directors. So school principals, we usually get it from school principals. The school nurse will call and say we have a high absenteeism with vomiting and diarrhea. We had a case where the school nurse called. She said, I have children having diarrhea, severe diarrhea. I mean, it was kids, she couldn't isolate them enough because there were so many. So that's an outbreak. They called us immediately. We went in and started an investigation. So those types of relationship and communicating with the schools and reporting to us timely so we can find out and identify the organism. Same thing with daycare directors. We get a lot of calls from daycares, which is good because sometimes they don't know what to report, and we investigate anything or any disease where there's 2 or more people with the same type of symptoms. So let's say a daycare calls and says we have 2 kids with this unusual rash. We're going to do an outbreak investigation because we don't know. We can't assume it's something, it's hand, foot, and mouth or something else. We have to make sure that we're mitigating and we're making sure that there's not a risk to the children or the staff or the family, you know, once the child goes home. So again, we expect and want multiple reports. And we want all, if we get 3 or 4 reports, as Dr. McIntyre says, we're good with that. But making sure that they understand what needs to be reported. So minimum data elements, name of disease and health condition. So you may not have a lab report. You may have a doctor in the hospital, in the emergency room. Patient comes in with stiff neck, headache, high fever. That's a diagnosis of meningitis. Suspect bacterial meningitis, they're going to call us. We don't need a lab report. If the doctor sees the petechial rash, thinks that we've got an urgent situation, you know, they need to call us. We're not waiting for necessarily a lab report. So that's what we're talking about, disease or health condition. The patient's name, their date of birth, their gender, address, and phone number. And that's important because the surveillance nurses, the epi nurses that are in the field, they do investigations based on the patient's residence. It's not where they're in the hospital, it's where they reside. So that's where our jurisdiction is derived by the patient's address. Date of onset, date of lab report, or date of diagnosis. So whether the physician in the ER is making the diagnosis of bacterial meningitis, or we get the lab result back, an enteric, a stool culture that says salmonella, or the date of onset, when did they become ill. And then we need the reporter's name, phone number, and the facilities organization, because we need to call them back and gather that clinical information, because one of our protocols is that before we call the patient, we're going to call a physician, because we don't want to be the first person to call that patient and say, you have salmonella. That is not good for our relations with the medical community because, you know, that's their patient. So we work and have to have that information from the physician so that we can make sure that we collect as much clinical information as we can so that we can rapidly investigate it. And I think we're going to take a break. Is that correct?
And so ladies, I'm going to ask you 10 minutes. Is that enough? That'll give you enough time to allow for questions there at the end? Okay. Well, we're going to take had a lot of information so far, but we're going to give you a chance to get up and stretch your legs. We're going to take a 10-minute break, and we'll see you back here at the Alabama Public Health Television Network. Welcome back to the Infection Control Update 2014. We still have a lot to cover, but I do want to remind you that at the end of today's program, you'll be given an opportunity to ask questions or email your questions in. Tina's already said if you don't ask any questions, she's going to feel like she's done a terrible job. So please, somebody out there, think of a question to ask for Tina. But honestly, this is the time to do it. You've got the experts here, and if there's anything out there that you're just not clear about, please feel free to call in or email your questions. So without further ado, let's get back to the training.
Back to it, favorite stuff, outbreaks. So looking at an outbreak, I talked a little bit about this. It's defined as an illness in 2 or more people from separate households with a common exposure. So this is looking at whether it's in a daycare, it's in a school, or maybe persons that went to a restaurant, ate a common meal together, and developed the same symptoms. So that's what we consider an outbreak. And we really work well with the BCL and the environmental services. They are just key for us in responding to outbreaks. So what happens first is we expect a call to either central office EPI or the local field surveillance staff, our EPI nurses. They should be called first. Sometimes it comes in a complaint from environmental. If they ate at a restaurant, they're looking at calling environmental to complain that, hey, we've got 10 people sick after eating at this restaurant. So we get many different reports. But the EPI staff, whether at the local or the state level, we get notified, and then we contact the facility to gather as much information. So whether we call the school, the restaurant, whatever venue that we're looking at. We investigate, as Dr. McIntyre says, ill and not ill. And generally, we encourage and we try our best to do at least 3 not ill to 1 ill. So we can really have strong data to have something statistically significant to be able to identify what is the common exposure, what's the organism, what happened. And so looking at sending specimens to the Bureau of Clinical Labs, food and clinical, to identify the organism. The county environmentalists are just key to go and assess the facility. The information they find with some of the outbreaks that we've had recently that Dr. McIntyre and we'll show how their work in the field helps us to really be able to know what happened. We can interview people all day and find out the symptoms, but if we aren't able to collect some of that information at the site, at the facility, then we've missed a huge portion of what happened. So we analyze that. We have a report on all our outbreaks. Those are on our website, and we give the report back to the facility. We review it with them, what happened, and we do education about how to prevent this from occurring again. New lab slip. So I wanted to talk just for a second about, we did change to a new lab slip in January. I know that there's updates regularly, so we kind of told our staff not to print them out, just go to the website and make sure that, because there are updates. And something that is new is that we're gathering insurance information. So when we're doing our outbreaks, we're also gathering insurance information on our patients as well. And now it is required. So looking at some of the things that I have highlighted or arrowed in are the ones that we're really looking for, doing PCR testing for norovirus or enterics, are the type of organisms that we're looking at. So we collect this information on the patients. We do not bill the patients because under our ELC grants we have money to pay for the testing for outbreaks. But this is something we are requiring and are gathering. So this is very new for us. It's kind of where we're going next. And so it's something that I'm sure all of you have heard about. So our test web page, there is a web page that lists the type of organism, the type of method that is preferred, and whether or not the testing is performed. So this is on our website as well as a resource. Clinical specimen and collection kits. We have enteric kits for Salmonella and Shigella. And then we also have parasitology kits. When we're looking at enterics, we said Salmonella, Shigella. And one thing with the enteric kits is we're trying to get that stool specimen. Usually we'll try to get a stool specimen in a sterile cup, because norovirus, we usually just need it in a sterile cup. And then if we're looking at a possible enteric, we split that specimen and we put some of the stool into the enteric kit, because it needs to get in there within 24 hours or we lose our ability to isolate that organism. So that's why we go over about the enteric kits as well, and you'll see those on the left. On the right, you'll see the parasitology kit. You know, we're looking at crypto. We do have crypto outbreaks. Usually we hear about those with water parks, where it's an organism that lives well in the water parks, and we identify that. And it can be hard to identify because it is a parasite, and when you're excreting the parasite, there's not always that being able to have that parasite there to identify. So usually when we're doing crypto specimens, we try to get 2 to 3 at least 1 day apart. So that's just something to know, that crypto is a hard organism to identify, but we do look at that because we do have outbreaks with cryptosporidium with water parks and other venues. This is a screenshot of our detect kits. We have these pre-positioned in the areas. We're trying to push out some more of to refill the kits. You have this, so you can collect food and clinical specimens with that. You see this spatula and other tongs to be able to collect the food as well as the clinical. So environmental sampling, collect as soon as possible, as soon as the outbreak's suspected, using aseptic technique, sterile containers, looking at 50 grams or 2 ounces of solid food or more, taking a representative sample. So we had a bean day outbreak. We had buckets, gallon buckets of beans. So, you know, we're not just going to get 1 spoon of the beans. You know, you want to get from different areas. And if you have a casserole and we think it may be the possible food that was contaminated, we're going to get it from different parts of that, not just one area. So that's what means taking a representative sample. And commercially processed foods, if we think that there's a product on the market that could be contaminated, we find out the lot number. Environmental helps us do a trace back or trace forward, and we collect those foods from where they were purchased. And this shows, it's a good visual to show the size, the portion of food that we try to collect, and identifying the product in the processor. Lot numbers are very important, expiration dates, use-by dates. And we need to keep them refrigerated unless collected frozen. So this is very important in trying to get the specimens to us. Submit solids in a sterile plastic containers or plastic bags, and liquids in plastic containers. One thing I'll also say here, especially counties, y'all are just critical to help us when we have outbreaks, that we look at when we're collecting food and clinical specimens, that we never put those in the same container, because that will contaminate our shipping box, because that will could possibly contaminate the food with the organism, the human specimen with the food. So we never ship those together, never put those in the same container. So that's just something to say, and I want to take this opportunity to thank you for all the support that you've done with outbreaks and helping us get specimens to the state lab. And this shows you what the packaging and shipping containers look like. And these are usually the flu kits, and to be honest, I've used these before and they're quite small, smaller than we like. We have coolers that are at the warehouse that we're trying to pre-position and get out because they are larger and can handle more specimens. But this shows that you have to have the frozen packs or ice packs. Never send specimens up without ice packs. And generally, I say 2. Because if it comes up without ice packs, we've lost the food and the clinical specimen. And that may be the only food, and it may be the only stool specimen that we get. And we wouldn't be able to identify the organism or confirm the outbreak if we aren't able to keep those specimens contained correctly. So unofficial epi logos, push stool rules. So as much poop as we can get, we try to, because it's just key in trying to identify what is going on. So at this time, I'm going to turn it over to Dr. Mack. She's going to talk about all the great work and fun that we've had in EPI with some of the outbreaks and what we've learned. So, Dr. McIntyre?
You're going to hear now about 2 examples, and I'm going to probably go fast because I want to leave enough time, at least a few minutes for you to ask questions. So get your questions ready. Go ahead and start sending them in. And specifically, we're going to talk about the two what we consider to be pretty significant outbreaks. We had a total of 86 outbreaks in 2013. And those outbreaks, the numbers of people involved in them really varied. We had some huge numbers in a couple of outbreaks. And so that's when you look actually at the investigations and cases, you will actually, that's on our website, you'll get an idea of the total numbers. We're talking about thousands of actual people involved, okay? So the two outbreaks that I'm going to talk about quickly deals with one that was in Jefferson County with sepsis and deaths at a dialysis center. And the other one involves the investigation that occurred with a facility that was actually doing cardiac light stress testing in Jefferson County. In that particular one, no one died. So that's always wonderful. You know, we always look at the fact about and try as quickly as we can to identify what the potential source is and to mitigate and stop it as soon as we can. So in looking at the specific, there was also the fundraiser meal. We called it and that was the Bean Day, okay? And then there's the one that we call the funeral outbreak that was associated with a funeral meal with Sumter County. And there were somewhere around close to 200 people at that particular funeral from multiple states. And then we had a Legionella outbreak in a nursing facility, nursing home in Lauderdale County. So and there was the Mercer event that at an orthopedic facility that was associated with injections. So these are what we considered our key outbreaks for 2013, but they were not all of our outbreaks. But these are the ones that gathered a lot of media attention, so that there were news releases, that we always have fun with calls from our media, okay? So let's look at the investigation at a healthcare facility in Jefferson County. And we were notified in May of 2013 there were 9 clients of a full-service spa, fitness, wellness center, and this is actually they also did stress testing with cardiolite. And this occurred with people ill on May the 7th and May the 9th. All individuals developed really high fever, severe chills, headache, and rigors, nausea within a couple of hours, 1 to 2 hours of the procedure itself. So when we looked at what is cardiolite, you know, we think about the injection when you're actually having a stress test done. So it's actually a radioactive material that gets injected. Usually is there's a time frame from the time of injection to actually going back and doing another look at the heart again. And this is exactly the procedure that was done to actually see if you can look at the specific muscle through the coronary arteries. So this gives you an idea of how it comes. Okay, the material, which is a radioactive tracer, is actually within the kits. Okay, and then the camera is able to pick up any activity related to that when it's injected. So what happened was ADPH and the Cardinal Health contacted all of the medical facilities that had received materials from these same 6 lots. One of the things that was done was to immediately identify within the facility with the patients who were ill is the lot numbers of the materials that they received as part of their injection. Because what we didn't want to happen is to have other people receiving the same medication, because at that time we didn't know whether it was the medication that was the source or specific what was causing it. So the immediate thing was to identify the lot numbers that those patients had received, and then Cardinal Health had distributed those materials is to identify all facilities that received any of the materials from those same lot numbers. None of the other facilities reported any events. So the other medical facilities did not report any illnesses in patients receiving them. So then we also made sure the Board of Pharmacy was notified, and they visited Cardinal Health, which is kind of like the actual compounding pharmacy involved in this. and they went in to make sure there was no problems there, because we have had some issues with compounding pharmacies, and all of you have seen some of that in the national news, and we did not want to make sure that we were missing anything, and so they went in and did not find any problems with the facility itself. So radiation control was also contacted, and this gives you an idea that it's not always Epi that's involved in it. When we identify that there are potential others that need to be included in these investigations, we get in touch with them. And because we were dealing with a radioactive material, radiation control accessed the procedures for producing the cardiolite and did not find any issues as well. So Epi staff actually visited the facility, went in, conducted staff and patient interviews, reviewed the procedures and policies, and basically walk through the actual steps that are taken in actually doing the procedure. Looked at the facilities for preparation, the whole 9 yards. Took pictures of every step, okay? Epi staff then interviewed the 15 patients that had received the cardiolite stress test at St. Vincent's main campus within that same week. So this is not something that we have time to spread out and say, oh, we're going to take our time. When something like this is going on, we want to make sure that as quickly as we can get a team in and get people involved and get the interviews conducted that we do, so that we don't end up with a situation that goes on and on and on and spreads throughout the state. So the investigation findings: many of the patients from the same main campus reported similar symptoms to those that were at 119, which is where the wellness facility was. Individuals whose stress test was performed at 119 were 2.5 times more likely to report nausea following the procedure than those who received it at the main campus. The frequency of other symptoms was not significantly different between the two groups, and the lack of sufficient documentation during the procedure, times, intervals of injection, comorbid condition prohibited more in-depth analysis. Why is it extremely important that people do their documentation? One of the things that was found that it was not adequately done. They didn't put down exactly the times that should have been recorded and the intervals between injections. So that kind of limited what we could actually find from the investigation itself. But what we did find, these are what we call the demographics and the symptoms. Where we went in and our actual number, when we look at the number of people involved in the health and wellness clinic versus the main campus with the numbers, okay? And what we were looking for is what we call a statistically significant difference as far as trying to identify whether or not, based on that p-value, there was anything that really stood out, and the nausea did. You'll see where the p-value there is actually 0.002, okay? So when we look at the testing of specimens, 8 used and 1 unused cardiolite syringe was actually submitted to the CDC for testing. Remember, I talked about, we have to know what our limits are, what we are really good and great at some things, not so good when it comes down to environmental testing with certain things. And so we use the experts. And the experts for this particular thing was actually CDC. And so we submitted that information through our state lab to them. 2 of the unused saline syringes were also submitted. Tests were done on all 8 of the used syringes and actually grew out Pseudomonas, okay? And I'm not going to try to pronounce it. Pseudomonas, contamination, okay? From all 8 of the used syringes. So then we looked at the unused syringes, and this was trying to make sure it wasn't a compounding pharmacy issue. None of them grew out anything. So then what happened within the facility itself to result in this bacterial being a source of this the outbreak? So then we looked at specifically, this is just testing results. I'm going to go over this in the time of because you'll have access to the actual handout. So when we looked at it, it's an opportunistic pathogen, okay, when it comes down to humans. It can be found on several environmental sources. It normally comes from soil in extremely wet conditions. So how did we end up with it in the syringes? Okay? So on 6/27 in 2013, remember that we've already sent staff out. They've been there. Okay, guess what? They went back, re-interviewed the IP, okay? Because there had to have been something that occurred that resulted in the contamination. During the subsequent call, it was revealed that the nuclear pharmacy technician, after delivering the cardiac dosage, would reuse the cardiolite syringe and needle to draw up the sterile saline from the 10 milliliter syringe and flush the line. Okay? Should not have been occurring. Okay? So then he would follow up with a sterile saline directly from the saline syringe again. And since then, he's been educated that this was not proper procedure and was educated to discontinue this practice. And there have been no further episodes. Okay? Although the source of the contamination remains unclear, improper practice techniques is likely how the contamination was introduced and occurred. So results of that. Now I'm going to quickly go through our funeral meal outbreak. And the church was in Sumter County. The meal occurred following a funeral. It occurred on July the 6th around noon. And there were, it says, approximately 100 family and friends. The numbers have gone as high as potentially 200 people were there, okay, attending the funeral. And we even had a couple of people from public health that went to this funeral, okay? So epi surveillance, actually, we were notified on July the 8th, which was that Monday, that there had been a surge in gastrointestinal illnesses that were reporting to the emergency room, okay? Symptoms included fever, diarrhea, and vomiting. And these 25 people that presented to the emergency room over that weekend were found to have all been present at one thing that was in common, and that was the funeral that was at the Eastern Star Baptist Church. Okay, and this was the initial report received. So immediately, Epi jumps and goes into their investigation mode. Attendees were found to be from 11 different states. And we even put on we have a national ability to put through EpiX information that goes out to all of the states within the U.S. that kind of tells them we've had an incident that we have believed that people from multiple states were present to try to get them to assist us in identifying potential cases. We did that. We went through CDC and issued an EpiX. And the 11 states that we actually had people identified from are here, including as far away as California, okay? 80 people were reportedly ill, with many of them that ended up having to be admitted to the hospital. Remember, funeral meal. 43 attendees were interviewed with outbreak-specific questionnaires, and 38 of them was ill. And we talked about trying to identify non-ill people that attended. It was almost impossible here because almost everybody that went and ate, they were sick. Okay, one attendee died in their sleep, and they were found on Tuesday morning. Okay. Friends reported that he had complained of GI symptoms on that Sunday. When he didn't report to work, somebody went to look for him. This person worked every day, and they found him. UAB autopsy was performed, and results did identify salmonella and was positive and consistent with the rest of the testing done. The clinical specimens were submitted for testing to BCL and to CDC, and environmental samples were collected from the church and actually tested. The people ill ranged in age from 4 years of age to 75 years of age, with the median range, median being about 35 years. 36.8% were male, 78.9% were African American. Okay, the symptoms, I had an incubation period that ranged from 2.5 hours all the way to 42.5 hours. When we looked at the symptoms, 100% of them had diarrhea. Over 94% of them had abdominal pain, and over 80% had fever that was greater than 101. So these people were really, really sick, which is why a lot of them ended up in the hospital. So when we looked at the epidemic curve with the illnesses, This gives you an idea of when they ate, when the symptoms occurred, and it differentiates the lab confirmed testing, because we did not get labs, some specimens submitted on all of them, okay? And then those that were probable, which were the ones with the symptomatology, and we did not get lab confirmation. So when we looked at the environmental assessment, the county environmentalists visited the site, took pictures of the facility, did swabs of the preparation areas, reviewed the temperature of the refrigerators. The menu included all of the items listed here, okay? Additional items that were brought in from the outside included barbecue pork, potato salad dressing, and the beverages. The refrigerator temperature when environmental tested it was 46, which was already warmer than it should have been. So you can imagine putting the amount of food that was required for the number of people that were present, which included 176 pieces of baked chicken and 176 pieces that were stored in the refrigerator raw after the chicken that was baked was also cooled for more than an hour, sitting on a sink, and then on a ledge with the wind blowing, the air blowing to try to cool it off, and then placed in the refrigerator. And then the raw chicken was put in because it was to be fried the next day. So some raw chicken sat next to prepared macaroni and cheese. And there was rinsing within the sink where the chicken had been washed of some of the other thing. And this is why it's so important that we educate people on proper handling and storage and food preparation. So cooked potatoes were drained in the sink where the raw chicken was prepared, okay? So there were 23 clinical specimens, and what did we identify? We are always happy when we identify actual sources, okay? Salmonella Heidenberg, PFGE patterns matched, okay? Blood and stool specimens from the deceased individual also identified the same organism. And there was also present Staph aureus, okay? So it wasn't just one organism. We actually identified multi-organism contamination. There was no norovirus, sugar toxins, or campylobacter that was identified. Among the 28 environmental specimens tested, the potato prep counter tested positive for the S. aureus, and we also identified samples from faucet handles, stove handles, knobs that were culture positive for B. cereus, okay? Genotyping or genome sequencing actually identified salmonella outbreak with a chromosome breakdown. This is how far we go, okay, and can go when we're looking at our outbreaks. So the epidemiological analysis found that the food items that individuals ate with the green beans were 27% more likely to become ill than individuals who did not eat the green beans. However, only 60% of the ill reported eating the green beans. Really, when we got down to it, the lowest attack rate associated with any consumed food was 90%. So the reality was it didn't matter what you ate, okay? So there was gross cross-contamination of the food items. The epidemic curve depicted a common point source of infection, and although the green beans exhibited only statistical significance, associated 95%, the reality was there was such a gross contamination that the culprit of the outbreak was unlikely only one food item, which meant that whatever, you could, with eating them, you probably got a huge dose of it from any of the foods, okay? Contributing factors associated with it was a mixture of cross-contamination, contaminated equipment, and improper holding temperatures and food storage. Uses of gloves while preparing food was not reported, okay? So here's the kitchen, not an industrial kitchen, just a regular kitchen, okay? A regular refrigerator, there's the little table area and the sink where all of this was done in trying to prepare food for over 100 people.
And they put it, can you go back? Mm-hmm. If you'll see the picture in the middle at the table, that's window air condition unit. So they placed the baked chicken in front of the window air condition unit for 1 hour to cool off before they put it in the small fridge. So if you, I mean, that refrigerator is much smaller than mine. And I, you know, again, 176 pieces of baked chicken, 176 pieces of raw chicken, potato salad that was prepared. And if it was 46 degrees on the day we went 3 or 4 days later, can you imagine what the temperature was
with
after
all of the
putting
warm
that hot
food
food? So that's where you really see the toxins start growing. That's why we had multi-organisms. That toxin just had that heat, it was ready to grow, and then the salmonella with the cross-contamination with the chicken. So that's why we had incubation periods. At short onsets was the toxin, the Staph aureus of the B. cereus. Right.
So one of the things, what we did get, we educated not only this particular church, but we also got calls from other people as a result of this, who were now kind of afraid of, with events and feeding, that staff went out and provided training on proper food handling and preparation, storage, making sure that the temperatures were correct, all of those things. So it ended up being a really, it was a bad incident, but it also resulted in us being able to educate a lot more people, putting information out specifically about how to avoid this.
And we also have a community DTR program that we're doing to reach out to the communities, especially these churches that may not understand the risk that they're putting themselves and others in when they're preparing such a large meal. You know, and I know they do it all the time. The church ladies, they really, you know, whether it's Vacation Bible School or, you know, a funeral meal or homecoming, to really understand about cross-contamination. So that's one of our pushes as well with the Laboratories, is getting out to the churches, because we want them to be aware of the risk and how to prevent disease. Okay?
All right, now it's a chance for you to call in or email in your questions. While we have Dr. Mack and Tina here, this doesn't make me want to rush out and eat, I can tell you that. And so, certainly not going to have any beans.
But no beans.
What I do want to ask, though, as we get started, is what is your recommendation for, you're talking about chicken being hot or something that you've cooked, now you want to store it in your refrigerator. Obviously, the lesson learned here is you don't put it in front of your window unit to cool it off, but how long should it sit out to cool off before you put it in the refrigerator and lower the temperature? Is there any recommendation?
You should never sit food out to cool.
It
you
should always
put
go
it in
directly,
smaller containers, not large containers.
Uh-huh.
Because sometimes, let's say you make a big pot of soup. You don't put the big pot of soup into the refrigerator. You store it in smaller containers so that it can cool faster. So never sit food out to cool.
So as soon as you can actually get it in there, the reality is, you know, if it requires putting a towel down in the refrigerator to sit it on because it's so warm, the quicker it gets cooled down, the better. The less likely there is for an opportunity to allow anything to grow. Okay? Now, that habit of sitting stuff out, you know, and I can remember this, you know, people sitting stuff cooking and just letting it sit on the stove is a no-no, okay? A lot of times while we have a lot of events, I mean, a lot of things occurring around the holidays is because people are doing more of that cooking and letting stuff sit out and people come by and nibble, you know. The key is that as soon as you can, after you finish, people have finished, the food needs to be broken down in smaller containers and put in the refrigerator. If they want to go and pull it back out later and get something out and warm it up, then that's wonderful. But don't leave it sitting out all afternoon so people can go back and forth to eat from it. Okay?
Well, Dr. Mack, you know, it's an old Southern thing to fry chicken and leave it sitting out on the stove all day. And I've actually seen on TV where they say there's something about frying the chicken makes it where it doesn't grow any organisms, and you know that's something that's on TV. But what happened to our public health employees that were at the picnic, or at the funeral?
Well, they became ill. I mean, we did have, and it was some like family. We actually got one of the calls from someone that worked whose, you know, son and daughter-in-law or someone was actually sick and hospitalized. I think 2 of them ended up in the hospital. So, you know, we have to be, I'm just going to tell you, I don't do it anymore. I don't eat at,
You don't do a lot of things anymore after work.
Okay, you know, I make sure I eat beforehand or I go to eat afterwards. You know, so you learn a lot of things based on stuff that comes through here that you don't do anymore. Like not taking your kids to a wading pool for swimming and stuff because of some of the things we had to investigate.
Okay, we do have a phone call from Crenshaw County. Hello, Crenshaw County. What is your question?
I would like to know what is the correct temperature for a refrigerator, and I want to know, this panel do conferences for churches?
We do.
Yes, 36 degrees for the refrigerator, and we go out to any church. The surveillance staff, the epi nurses, are trying to go to all the churches in their public health area. If you know of one that you'd like us to go and do a presentation, just let us know. It's a high priority for us because there will be, legally you can be sued civilly. Churches are not exempt. I mean, the insurance may cover some of it, but these churches are being sued. And so, I mean, you can think about what that does
to a small
to a small community. It's really sad.
Okay.
Okay, thank you.
All right, we got a question from the audience.
Yeah, this is John Hankins. One of the things that people tell me when I give them this information, and if I've heard it once, I've heard it 100 times. I grew up with my mama cooking lunch and it being left on the stove, and we had it for supper. And every Sunday, that's the way it went, and nothing happened to anybody. Everybody did fine. Is there something different today than it was then? Because you didn't see a lot of food poisoning back then.
Well, one of the things you have to think about is that our food sources, and I'm just going to say this, there is a lot more. We used to hear people that ate raw eggs and didn't have a problem. There is more E. coli and other stuff associated with foods. I'm just going to say that because it is. And we also used to a lot of times get a lot of our stuff that was homegrown and didn't necessarily go through the process that it does now when it's coming down to it. And I've looked at this, we look at about what our systems are. I think some of us may have been exposed to a little bit more growing up too and may not have had as much of an issue. But the reality is that there is bacteria that we know exist within the foods. We talk about the fact that salmonella is there, like in raw chicken, okay, and how we have to make sure that we're handling our food surfaces, like where you prep and prepare food. Don't prepare raw chicken and then turn around, even if you clean it, and prepare vegetables on the same cutting board, okay, even if you cleaned it, okay. There are just some common sense things now that we need to understand. Okay. So pay attention to those things. It's really not recommended. How we have a tendency to wash the chicken. It's not really recommended to do that, but I'm going to have to be honest. I wash mine, but I don't turn around and put anything else in that same sink. I Clorox, do my 1 to 10, disinfect, and then leave it alone. I don't drop potatoes in it and do all of that. I'm going to do my preparation for all of my vegetables and other stuff before I do anything when handling any raw meats. Okay. That's just the reality. So we have to be able to know that there are certain things that we can do to avoid getting sick. And that's in food preparation, doing it correctly. We have flyers out on our website that's available for people, for not just our staff to use, but also for people that are out there. We refer folks all the time. There's a cross-contamination prevention information out there. There are flyers about salmonella, signs and symptoms, all kind of information that makes sure that we can prevent this from happening.
And that's in our EPI page.
Mm-hmm. Okay. Do we have any emails or
let me check.
Any other questions from the audience? Okay. And right now, I know that there are no more phone calls, and without any more emails, we're going to go ahead and close the program for today. I know that if there's something else that comes up, I know you know how to get a hold of Tina Pippin or Dr. Mack. Please feel free to contact them if you have any other questions. It's been a wonderful, wonderful show today, ladies. You did a fabulous job.
Thank you.
So I want to remind you that if you do want CEUs, you have to register and fill out the evaluation form and send it in. Other than that, thank you for joining us today at the Alabama Public Health Television Network.